And now, the DPP Rally Talk Show with Claudia on the Cough 360 Network. And here's your host, Claudia Morandi.
Good evening, everybody. I am Claudia Morandi. I will be your host this evening. As a reminder, we protest again on October 16. Visit our website, don'tpunishpainrally.com, to find a venue near you. Just remember, if you can't get out to one of the larger protests, grab some signs, head over to your local pharmacy, and get that press release out, and we will help you promote. Tonight's guest is a senior fellow at the Cato Institute and works in the Department of Health Policy Studies. He's a surgeon, the founder of Valley Surgical Clinics in Arizona. He writes extensively on both regional and national policy on the harmful effects of drug prohibition, and he's highly respected in the pain community. Welcome to the show, Dr. Jeffrey Singer.
Well, thank you for having me.
So we have a number of questions, Dr. Singer. I know you're very busy. Thanks for taking the time out of your day to be with us. You know, there's so much struggling in the pain community. One of the first questions somebody has, what kind of doctor are you?
Actually, I'm a general surgeon. So I treat pain in a different way. So I usually treat people who come in with either acute pain from an acute surgical problem, like an acute abdomen, as we say, or sometimes they have a chronic pain condition that needs surgery. That's usually involving the abdominal cavity, and then of course I have to manage pain after the surgery. A lot of times my surgery itself creates a lot of pain that needs to be managed. And also over the years I've treated trauma patients as well, which have their own pain due to that.
And you're still seeing patients, correct?
Yes, I'm still practicing. I've been in practice since 1981 in Phoenix, Arizona. I received all my education and training in New York City, and I've always also been very much interested in public policy. So I've been involved with the Cato Institute for several years. The last few years, I've been a senior fellow there, and I divide my time between my medical practice and my policy work at the Cato Institute.
Now, this may sound like a silly question, but has policy affected your ability to treat your patients?
Yes, not as much as it's affected the ability of primary care physicians or pain management specialists, but yes, it has. What's happening, and this probably happens in every state, my state of Arizona has imposed limitations on how many, on the amount of and number of days of pain pills that doctors can prescribe to patients. In our state, it's mandatory that before I can prescribe to any patient, no matter the circumstance, no matter how well I know the patient, I must access the prescription drug monitoring program, or else I can't do it. And it's linked into the electronic health record system. In fact, they passed legislation here in Arizona. It took effect the first of this year. And ironically, it was rushed through the passage in January of 2018. The governor called an emergency session of the state legislature to deal with the opioid crisis. And I actually had requested a meeting, and even the state Medical Association and the State Osteopathic Medical Association had written letters saying, we get rumors that you're thinking about putting limits on the dosage and the amount of prescription pain pills that doctors can prescribe, and that's a bad idea. Without any hearings or anything, the bill was introduced on a Monday when the legislature was called into an emergency session and was signed into law on Thursday.
Yeah, funny how that happened.
Yeah, no hearings, nothing. And interestingly, it passed unanimously, even though several of the leaders of both parties at the time of the vote were saying, why do we have to do this so quickly? It doesn't take effect until next year. Don't we have time to get opinions? Well, it's an emergency. It's such an emergency that it didn't take effect for a year later. Very frustrating. So I'm affected by it too, because lots of times I'll do a major operation on somebody, and when they get now at the in where I practice in Arizona, if I want to post-operatively order morphine for them for their surgical pain, I have to get them now, believe it or not, to sign an informed consent. I don't know if this exists in your state, where they have to say, I understand that I'm being prescribed an opioid, and this has a very high addictive potential and a very high risk of overdose, and I understand the risks I'm taking. And of course, it gets me angry every time this occurs. Those are the rules of practice at the hospital, because I also know it's all misinformation, and it's scaring patients. And a number of patients I've had recently have actually refused pain medication, and it's like I'm practicing back in the old days when I just started, where I'm seeing patients in a lot of pain, and when I offer them pain medicine, they refuse because they, quote, don't want to become addicted. It's like we're back into the 1960s and 70s again.
It's so draconian, so barbaric. I'm actually, I get called in to advocate a lot for post-op people. And, whenever I meet with the surgeon, I said, I have an expression that I live by: the man who pays, saves. And I'm telling my patients, do not have any type of elective procedure unless you have a plan in place, because there's so much paperwork that doctors have to fill out, and the PDMP seems not only confusing to doctors, it's a hassle. And I don't know if a lot of doctors understand it. So I want to, let's talk about the PDMP, because, a lot of the people that listen to the show, they're lay people. How long has the PDMP been in existence?
Well, first of all, it's very good that you bring this up, because for those listeners, if you're interested in this subject, I'm actually moderating a policy forum that I put together. It's going to be at the Cato Institute on Thursday, October 3rd in Washington from noon to 1:30 Eastern. And if you can't get to the event where you could sit in the audience and ask questions, it's still going to be live streamed, so you could still watch it from wherever you are by just going to the Cato Institute website. And it's later going to be recorded and archived. And to get to it, you go to the website is cato.org. On the top of the web page, you'll see the word events. So if you click on events, it'll take you to that one, and you just click on that, and it has all the information on how to register for it and or to live stream it, and it's free. So we're going to be going into this in detail, because there haven't been enough discussions about this publicly. But the first PDMP, actually historically, to my knowledge, was created, I think, in 1939, a long time ago in California. So, of course, this is in the days before we had the technology we have today. So there have been efforts over the years in different states to try to keep track of different controlled substances and where they're going to, et cetera. But they really started to take on steam in the early 2000s, after the all of the attention was given to the overdose crisis. So that now essentially every state plus a District of Columbia has one. In Missouri, it's a little kind of
Missouri does
patchwork. Yeah, but they're still kind of doing it. It's like the counties are doing it, and they're trying to cooperate with one another. So for all intents and purposes, it exists everywhere, and about more than half the states now have what they call a mandatory PDMP. So in Arizona, up until a couple of years ago, it was there for us to use if we wanted to, and that's all. And now I got issues from a privacy standpoint as well. What right does the state have to put private medical records out there for anybody in law enforcement or in another medical practice to access without consent? But taking that out of the picture, just from the standpoint of being a practitioner, I could see the value of something like that, as long as it's not mandatory and it's there on an as-needed basis. So, for example, over the many years of my practice, I would get some patients who I have a sneaking suspicion they're really not, pain is subjective, so they come in complaining of exquisite pain, and then they ask me for a prescription for their pain, and I have a sneaking suspicion just by the way they behave, the way they're asking, that maybe they're trying to trick me to get a prescription. And in those kind of cases, it would be nice for me to be able to find out if I'm like the fourth doctor this week that this person has visited and got a prescription for each one. So that could be useful on an as-needed basis. But on patients that I know, or under circumstances where I know, I don't like to be forced to do it. And the fact that I'm forced to do it, there's information suggesting, there's evidence suggesting that it actually tends to make doctors not do it, not prescribe pain medicine. And I could understand why completely, because I find myself, I hate to admit it in public, but I find myself falling prey to this as well. When I have a very busy office hours, lots of patients, maybe we're running a half hour behind, and there's somebody who's coming in pain, and I'm thinking if they ask me for a prescription, then I'm going to have to spend a lot of time going through all the steps that's required for me to be able to get that prescription to that person, because first I have to log on to the special site, and then it has to be authenticated, and then it has to be approved. There's a whole bunch of steps, and it slows you down.
Oh, wow. I didn't know that.
And that's the way it is in my state. And every once in a while I have to call in the person in my office who's really the tech guru in the office and say, "Did you come in here because I can't get this to work?" There have been some times where it's taking me 10 or 15 minutes just to send in a prescription for a painkiller, just because I can't get the darn thing to work well, and then I did it, but then it doesn't go. All those kind of things. So what happens is when you're in a rush, you're thinking this is the last thing I need to do right now. So there's a tendency to hear yourself in your mind saying, "Oh, please don't ask me for anything for pain because I don't have time for this." This is what's kind of influencing you as a doctor. So I imagine if this happens to me with my views on this, I can imagine how it happens to the practitioners who don't have the strong views that I do. So, and there is evidence that it just tends to discourage doctors from even wanting to bring up the subject of "Are you hurting?" because they don't want to know the answer, because it may give them an additional assignment. It's perfectly understandable. It's a normal human response, but it's not good for the patient. So anyway, so that's where we are right now. Now, there are a lot of issues associated with it. There's been a lot of evidence to suggest that since the PDMPs have been around, they've been successful in driving down prescriptions. And I just gave you one reason right there. Also, that the fact that doctors know that every prescription they write is under surveillance, and then they pick up the newspaper and they read of a story of some doctor who's, being indicted for murder because he wrote a prescription that was traced to somebody who was found overdosed, and the prescription he wrote may have been a couple years ago, but he was the last one to write it, and now he's being indicted. So a whole lot of doctors are just getting so terrorized by this that the knowledge that every prescription they write is being watched makes them not want to write them. So there's no question in my mind, and the data suggests this as well, that prescriptions are down partly because of the presence of PDMPs. But there's also evidence, and we're going to learn about this at the conference on October 3rd, that they may actually have been driving non-medical users to the more dangerous drugs on the black market, like heroin and now heroin and fentanyl. Because by reducing the number of prescriptions, you're also reducing the number of prescriptions that can be diverted into the black market. And so when non-medical users are using diverted opioids into the black market and they can't get them as easily, they go to the next easiest thing. And as I'm sure you know, for the last several years now, heroin has been actually cheaper and easier to get than bootleg OxyContin or something like that. So there's also reason to believe, therefore, that the PDMPs are driving non-medical users to more dangerous drugs and contributing to the overdose rate in that way. And then there are also, of course, the effect this is having on patients who are in pain, because the PDMPs is making doctors reluctant to prescribe pain medicine, and there are people who are suffering. I think we're going back to the way it was prior to the 1980s. I remember back in the early 80s, I'd be making post-op rounds on my patients, and I'd see patients who were obviously, in pain, rapid pulse, sweating, pasty looking, and I hyperventilating, and I'd say, "Are you in pain?" "Yeah, I'm in pain." "Well, I just let the nurse know I have morphine ordered for you." No, I don't want to become addicted. And I said, "No, don't worry about that. That's what this is for pain. You use it for this way. It's not a problem. Just use it." And so back then, both the patients and the doctors had been indoctrinated by the drug war, and so we were reluctant to prescribe, and patients were reluctant to receive. But then throughout the 70s, 80s, and into the 90s, we were seeing lots and lots of literature telling us, you guys are over. It's an irrational fear. The risk of addiction actually is rather low especially when it's used as prescribed in a medical setting, and the overdose rate when used in a medical setting without a lot of other substances is actually really low. So you should be prescribing it. So by the late 1990s, doctors and patients were both getting much more liberal with prescribing. Well, I've written about this extensively. There's a research showing that the overdose rate has actually been on a steady exponential increase since the 1970s, and so there's no evidence of slowing down. The only thing that's changed over the years is which drug at any given time is the most predominant one from which people are overdosing. So there's evidence that the so-called overdose or opioid crisis was actually going on before the prescription opioids were part of the problem, and now, of course, we're way beyond that, because prescription opioids are only a tiny segment of the opioid-related overdose deaths. The overwhelming majority are heroin and fentanyl, and now, of course, we're seeing a re-emergence of stimulants like methamphetamine and cocaine as a cause of the deaths. So anyway, we finally overcame those fears, but now we're going back to those days the way it was, where patients are afraid to take it and doctors are afraid to prescribe it. But the doctors who are afraid to prescribe it are afraid for a different reason. They used to be afraid because back in our day, when I was a student, we were indoctrinated into thinking that, you take just one injection of heroin, which is diacetylmorphine, half the strength of Dilaudid, just one injection, you're hooked for life. And they were telling us that stuff. So but now we're not afraid for that reason because we know better. Now we're afraid because we just don't want to get into trouble with the law.
Absolutely. I'm going to sneak in a caller. Hi, caller. Do we still have... Hi there. We have Dr. Arnold Feldman on the phone.
Hello.
Hi, Dr. Singer. How are you? Can you hear me okay?
Yes, I hear you fine. Thank you.
Yes, I'm driving. I apologize. Quick question. First of all, thanks so much for participating in the discussion. I'm a pain practitioner from way back when, and I've been around this rodeo a long time, and everything you said just now is absolutely true. I have a very different or a short-term goal in mind, and it came to me from an African-American doctor who was a pioneer in civil rights in Mississippi, and he told me a year and a half ago, unfortunately he passed away, the Reverend Myers. He said, right now what we need is the DEA front and center in front of a congressional oversight committee explaining why they're breaking the law. And I can tell you right now, there will not be a doctor left to practice pain medicine except for injection therapy within a year and a half. I just spent my last week in Forest City, Arkansas, visiting a colleague that's in federal prison. I have another colleague that's in federal prison. I know a man who's going to be probably sentenced to life in prison by some judge in Virginia. And, all of these studies that you and I know that there is a great difference between the pain patient and the addicted patient, and the overlap is small. So my question to you is this: what do we do, we meaning the medical community and the patient community, which are obviously bonded in this quest, what do we do right now?
Well, each of us has different based upon our situation, to do different things. So in my case, I'm a policy analyst at the Cato Institute. So I've been doing a lot of writing and testifying before committees and appearing in media events and hosting conferences, hoping to influence the thoughts out there, influence the opinions of policymakers. Different people can do different things. I think it's very important, and I'm very disappointed that our medical associations, our professional associations, haven't spoken out more. Now, the American Medical Association, they were a little late to the game, but at least finally, about a year ago, they started speaking out about all these prescription limits that have been imposed on doctors and the misinterpretation and misapplication of the 2016 CDC guidelines. But better late than never. But they've been late to the game. I think this, the way I look at it, this is law enforcement and politicians practicing medicine. They're trying to dictate to doctors how to practice. Now, you and I both know as physicians, and patients know this too, everybody has a completely different response to different medications at different doses. Every single case is different. The problem when you make policy is, of necessity, policy has to be one size fits all. Policy can't be nuanced, but treating patients is nuanced. So that, for example, and I'm just giving this is I forgive me because you know this, but the non-doctors out there listening, this is an example for them. When I prescribe, let's say, oxycodone for a post-op patient, I'll have one patient tell me that was too strong, made me sleepy. Do you have something milder? But another person will tell me that didn't do anything for me except get me jittery. Could you recommend something else? So the point is, based on a person's genetics and epigenetics and metabolism and a whole lot of other factors, different people respond differently to different medications. That's why anytime I hear anybody say the only way to treat condition X is this way, I'm immediately suspicious of that person, because it's just not ever going to be the case in medicine or in surgery, for that matter. In many surgical conditions, there are several different ways you can approach the patient surgically, different operations you could do, etc. So that's the problem when we have policy that's trying to impose these guidelines on us, and we need to. Patients need to speak out, and we need to. The people who need to hear this are the politicians. The politicians basically are they go whichever way is going to help them get elected. And right now, if you're not a pain patient, and then you're generally in the. If you're a pain patient, you're generally in a minority. So the majority of people out there who are hearing the complaints of pain patients, they may be getting empathetic and sympathetic, and they may, for a few minutes think about it and say, gee, that's a shame, but it doesn't really affect them directly. So they're not putting pressure on the politicians. Another thing you made me just think of, and I'm actually I'm going to be blogging on this tomorrow. As you probably know, the DEA, the Drug Enforcement Administration, just a week ago or so, listed their proposed cuts in production of opioids for 2020. For the last if these cuts are put into effect, they have a request for comment. Then it'll have been a 53% reduction in production of all prescription opioids since 2016. And already about a year ago, there was an acute hospital shortage of injectable opioids due to this. To ask a government agency to be able to decide, and they're required to do this, but to ask them to decide how many injectable and non-injectable opioids will be needed by a population of 325 million Americans to control their pain or perform anesthesia in the next year is such a ridiculous question to ask. And yet they're asked to do this, and so now they announced in their proposal for 2020, they proudly proclaimed that we have found that due to our efforts thus far, only 1% of prescription opioids get diverted into the black market, and now we're proposing an additional overall 10% reduction on top of what we have. So I'm thinking to myself, well, if the ostensible reason for the DEA to be reducing the number of opioids prescribed is because they believe that if there are too many opioids prescribed, then excess ones get diverted into the black market for non-medical users. They've already told us they pretty much got that problem licked. 1% diversion rate, it's pretty much none. So then why are they reducing it further? I can't understand why they're reducing it further unless the DEA believes that opioids are bad and they addict people, in which case they're trying to regulate how practitioners treat pain. And that's not where they belong. That's law enforcement's wheelhouse is enforcing the law, not practicing medicine.
So I have to intervene because I have two doctors on the phone. Dr. Singer, Dr. Feldman, why is it so difficult to organize doctors to get 300 doctors in one place before Congress and say enough is enough? There's no data suggesting that these opioids are the cause, or overprescribing is the cause of the opioid crisis. But why is it so difficult to get, just in my work as an advocate, trying to get doctors are busy, and a lot of them, they just bury their head in the sand, but I don't know how it can affect change.
Let me go first. The last thing you say, bury their head in the sand. I've been in practice for many years, like I say, and doctors, first of all, doctors are obviously very smart. They had to be to get to where they are, but that doesn't necessarily mean they're informed about things outside of their area. That's number one. Number two is they tend to be they're very good at complaining about things, but they don't get themselves informed as to why things are the way they are and what they can do about it. They tend to bury their head in the sand. Whenever I'm showing up in the doctor's lounge at the hospital for a cup of coffee, I'm very commonly hear lots of people complaining, but nobody wants to do anything about it. That's my end. What do you have to say, Doctor?
Well, I have developed a slightly different viewpoint over my experience, which you and I can discuss at another time. But there's a group of people that are key to this discussion that are not even in the discussion, and that is the medical boards of the United States. The medical boards essentially are the hench people that do the work for the DEA, either by prosecuting doctors themselves or referring them to law enforcement. So these boards, which you thought were reasonable people run by doctors, are now run entirely by non-doctors, mostly attorneys. And so therefore they generate millions of dollars in fines and fees by prosecuting doctors. Number two, the DEA makes millions, if not billions of dollars by seizing assets. So this is now the name of the game on the surface is we protect the public, we're stopping this addiction crisis, but the real thrust is to seize assets. And so there is going to be filed a lawsuit in the next 2 weeks or less against the medical boards of the United States of America. And this will, of course, be quiet, but we're going to try to publicize this, and we will hope that we can get you and yours interested in this, because it reminds me of my wife tells me don't bring this up, but in World War II, it was a very difficult task to round up German and European Jews and kill them. And the Nazis actually brought in deputized people that they called the Einsatzgruppen. And essentially the medical boards are now the deputies of the DEA. And so it's a much bigger game now. It's a lot more than just solving the opiate crisis. It's seizing millions and billions of dollars. This man in prison in Arkansas was a very successful doctor. And they took everything, his house, his cars, his condo, his boat. And they can take that in pre-trial seizure laws. And all of this has to come in front of the Congress. This was not intended. This was intended for mafia kingpins, not for physicians.
Well, I got to tell you, some of this is going to be discussed at the conference next week. We have one of our speakers is Nathan Wessler, who's with the ACLU in New York, and he has written an amicus brief in a federal case in New Hampshire. Well, you probably know the New Hampshire PDMP. The DEA asked the New Hampshire PDMP if they could kind of go through it, kind of trawling, looking for possible people to indict. And apparently the New Hampshire PDMP said, "Do you have a warrant?" And they said, "We don't need a warrant." this is the war on drugs. The warrant's not necessary. So that's gone to court, and the ACLU believes that yes, you need a warrant. That's a otherwise it's a warrantless search. So we're going to talk about that.
Just to add some hyperbole, my license was suspended some years ago, and my suspension is now over. And then when I reapplied for my license, they said, well, by the way, if you want your license back, you have to write us a check for, you ready for this? $500,000.
Okay.
So, needless to say, there's something added to this recipe, and the recipe is now, let's have all your money. And so, until this is front and center, like Reverend Myers told me, until this is front and center in front of the United States Congress, with an oversight committee, the DEA is going to do whatever they want to whomever they want. And the corollary of that is any doctor that practices pain medicine legitimately today is putting him or herself at risk.
Dr. Feldman, thank you for calling in. We've got a list of questions here.
Great, Dr. Singer. Hey, great to talk to you. Thank you so much.
You're welcome. Thank you.
We're going to do our quick round. We got a lot of questions here for you. Somebody wants to know, we have two Jessies. One Jessie's in Hawaii. Are you familiar with Andrew Kolodny and PROP? And did they accelerate this nightmare?
Of course, I'm familiar with him. I disagree with him. I think he's given advice to many of the current policymakers, advocating a lot of the policy that's in place today. I don't want to get into any sort of personal attacks or anything like that, but I strongly disagree with him, and I think he's helped fuel the fire by convincing policymakers that we doctors are hooking patients on opioids and that we're responsible for the overdose crisis. Now, do some doctors overprescribe opioids for their patients? Undoubtedly. I know doctors who overprescribe antibiotics or overprescribe antihypertensives or even treatment for diabetes. There's no question. There's also a wide spectrum of opinions among doctors where reasonable people can disagree, where good doctors could disagree as to what's the proper dose. And as I said earlier, medical care is nuanced. So a dosage for one person may be a high dose, but for another person it may not be. So, but if I said that every single doctor has been an angel and been doing everything perfectly, I wouldn't be telling you the truth. But the notion that is at the heart of the problem is completely off base. Also, have there been doctors who've been operating pill mills? Of course. We all know about it. We see stories of doctors. There was a doctor in Orange County who was arrested for selling OxyContin prescriptions at Starbucks for $600 a prescription. There are all these documented cases where doctors had deals with drug dealers where straw patients would come in, they give them a prescription for huge numbers of prescription opioids that didn't get filled at a participating pharmacist who was part of the ring, and then they get sold on a black market. But if you want to know what to blame for that, there's an obvious blame, and it's not the patients or the doctors, it's drug prohibition, because drug prohibition brings out the worst in people. It corrupts policemen, it corrupts prosecutors, it corrupts politicians, and it corrupts doctors and pharmacists. So those doctors were basically using their medical degree to deal drugs because there's a lot of money that can be made dealing drugs. So, yeah, we get those anecdotal stories, and then it's very understandable how people would like to have a simple explanation. Simple explanation. Doctors prescribed too many opioids, they hooked everybody on drugs, and now we're paying the price. No. Those are anecdotal stories. They're real stories. The cause of most of those stories is the fact that drug prohibition corrupts corruptible people. And so if you're looking for something to blame, at the end of the day, blame prohibition. Don't blame doctors treating their patients.
I testified not too long ago, and I have to go up against the chief of the Department of Health in my state, and he said, overdoses are down. I said, if overdoses are down, it's probably because naloxone is being given about 50 times an hour, and I'm in Rhode Island.
Yeah, definitely. They're down in states that had a high overdose problem. For example, there's data now from Ohio. particularly around Cuyahoga County, where Cleveland is, where the overdose rate has come down significantly, and it's largely due to harm reduction, which is what we should have been doing in the first place. You see, if in the first place we recognized that the overdose crisis, and it's reached, proportions that we never had before seen in this country, and it's no longer confined to marginalized groups in the inner city, but to everybody. So that's why it got everybody's attention. But most of this is, again, due to people using drugs non-medically in the black market. So what we should have done from the get-go is address, talk about the big elephant sitting in the middle of the room, which is drug prohibition. Now, I understand politically it's very unrealistic to consider that at this stage of the game, the politicians will consider decriminalizing drugs. Of course, they did that in 2001 in Portugal, and it went from being one of the highest overdose countries in the developed world to now one of the lowest. But aside from that, if we don't have the political will to do that, at least do harm reduction, because there always will be, and there always have been people wanting to either self-medicate or recreationally use, or for whatever reason use drugs in the non-medical area. And if we recognize that this is always going to exist, and our concern is that people are dying and that disease is getting spread, if that's the reason why we're upset, and that should be the reason why we're upset, then let's focus on things that reduce the chances of that happening. Naloxone has been around since the early 1970s, and it's a proven antidote. It's used by a whole lot of non-professional people, first responders, caregivers, and in fact, in Australia and in Italy, it's over the counter, like you could buy like a box of Band-Aids, or you could buy some naloxone. In our country, it's still considered prescription only. Now, all 50 states have figured out a workaround so that either they've authorized the pharmacist to be the prescriber, or in some states, like my state, the medical director happens to be an MD, and she has given a standing order to all pharmacists that if somebody comes up to you wanting some, you have my permission under my name to give it. But still, the experience has been that most people are not availing themselves of that because there's such a stigma attached now to opioid use that people don't want to go up to the counter and ask a pharmacist if they could have some naloxone, and probably have to fill out some paperwork and explain why. And there are some pharmacists, believe it or not, who don't want to give it out because they believe that's enabling drug use. Could you imagine if pharmacists didn't want to give out insulin to diabetics because it's just enabling their overeating? But in any case, so that's a problem. The solution is to make it over the counter. The FDA for the last, I think, 3 years now has been publicly saying, we think this is ready to be considered to move over the counter. We invite the manufacturers to petition us to do so. And the manufacturers haven't done so, and for obvious reasons, because they can make much more money if it's a prescription-only drug. Once drugs move over the counter, prices come down. But
I have a question from Diane. I'm going to sneak in a quick question for you. A lot of questions here. Diane asks, if the DEA backs off and the CDC pulls or rescinds the guidelines, do you think doctors would feel comfortable prescribing pain medications again? Would the doctors trust the government?
You're asking me this from Diana?
Yeah.
Okay.
Yeah.
I think it would take a little while because, it only makes sense that just like it took a while for doctors to go from under-prescribing to prescribing in a more humane fashion. Now they're frightened into under-prescribing, and they're going to probably have to wait a while to make sure it's for real, and they're not going to change their mind again. But I think eventually, yeah, if the DEA and the CDC basically relented, it'd be nice if they, accompany that with some sort of official statement. Over a certain reasonable period of time, more and more doctors will resume their previous, practice habits, because most of my colleagues who've gone to reduce, now I'm being anecdotal, most of the colleagues I speak to who tell me that they've cut back on their opioid prescribing say it angrily, because they they don't believe they're doing the right thing. They're doing it out of fear. They're not doing it out of a belief that it's the right thing to do.
What a shame. Oh, my God. Who would ever think? It's history repeating itself, and it's going to have to repeat itself in order for our country to be in a good place again.
Yeah, this happened back in the 1920s. You aware of that?
Yeah, I've done my research, and I said, this is ludicrous. It really is, and prohibition just makes the world a much crazier place. And it's how long do you think the pain community is going to have to suffer? What do you predict?
I have no way to predict that. I can only say that when it hits a point where so many people are angry because they're being treated in a primitive fashion by a primitive understanding of opioids and of addiction, then they'll make some noise. The only thing that makes politicians listen is when they're worried about getting reelected. And so it has to hit a critical mass where enough people are angry where it becomes, a leading story on the news.
And we take their seats. And, that's what we do, the Don't Punish Pain Rally organization. Every time we protest and we set up these rallies, we meet with lawmakers and we say, look, if you want your seat, there's millions. We don't know how many. I spoke with somebody from Frontline, and he debated how many pain patients, how many chronic pain sufferers there were. And he said, I think 50 million is too high. I said, you know what? After 25 million, who's counting? He said,
yeah.
Right. And I don't think anything is going to change without people getting super angry, demanding change, or, in a perfect world, we really need 10 senators to acknowledge the problem. And I know that's going to happen. And one day we're going to see on the news the senators shaking their fist at the sky, asking, how on earth did this happen? I think we really just have to wait until Congress, they're directly affected.
Yeah, when I go to Washington, I oftentimes meet with staffers to the senators and representatives on Capitol Hill, trying to persuade them and influence them on policy. And some are getting much more sensitive to the idea. For example, there are a couple of Senate staffs that I've worked with that seem very sensitive to the idea that the pendulum swung too far in the wrong direction, and to use their words, and that people are not getting under-medicated for pain. So it is starting to get around. The message is starting to get around, but we've got a long way to go.
Yeah. And, one of my senators, I'm not quite sure what he does, if he's been lobotomized, but he refers to it as the overcorrected CDC guidelines. But the other senator says it's a thorny issue. However, my senator, Jack Reed, always intervenes on veterans' behalf. And when I contact the senator's office, and if we've got vets listening out there, you have to fill out a constituency request form. And your senators will have access to your medical records, and they get involved. And you have to insist. And if it doesn't work, you've got to call your television station, and you've got to get media. And now is the time. Media wants to hear from doctors, especially. That's a constant problem with organizing. My media always says, I need doctors. I need doctors to speak on camera. It's hard to get doctors.
There's another lesson. What this all amounts to is, people who don't know anything about medicine, practicing medicine. We're having to ask senators and congressmen if it's okay for us to get treatment for pain, or if it's okay for me as a doctor to treat somebody in pain. Why am I asking somebody who's got maybe a business degree and never learned anything about medicine? Why am I asking if it's okay if I treat my patient? This is a word of warning, okay? The more government gets involved in any aspect of medicine, the more this is going to happen. So this now is affecting the pain community. But wait for other patients and with other medical problems to get affected also, because we basically are insinuating the government and policymakers into the practice of medicine and between the patient-doctor relationship.
Yeah. I have a lot of emergency room doctors. I don't know how they find this show. They must be bored overnight. And they'll send me emails, and they said, one ER doc said, let me tell you, Claudia, when government interferes with the practice of medicine, bad things happen, instead of bad things are happening. And I said,
right.
And you just don't know how to answer these doctors. It's so frustrating because on a local level, when you testify at a state house, and you go before these country bumpkins that are making laws, they're like, nope, we're going to have you fill your script for 3 days. And I say, oh my God, what do you do for a living? Who are you? And why are you discussing the practice of medicine? And why is the governor allowing this to happen? When is enough enough? You want to talk about fed up, the organization fed up? We've got people that have been deleted from the equation. People with pain have been eliminated, wiped off the planet. This community is fed up. How can we support our doctors? It's not just doctors. It's you, basically. This is basically each of us as an individual fighting for a right to control our own lives, actually. And so it's not just MDDO doctors. There are all other kind of healthcare practitioners, nurse practitioners, physicians, assistants who are trying to help people, and all of us are being interfered with. This is a sacred relationship between a patient and their provider, healthcare provider, and it's just important for everybody to speak out, write your representative, attend rallies, do whatever is in your particular area where you have the strength. Like I say, in my area is in writing and speaking and publishing papers and doing public policy research. That's where my strength lies. So that's what I could do. But different people could do different things based upon where they are in their daily life. I have a question about policy, because a lot of people don't even understand what that word means. What is policy?
Policy are basically rules that go into place. There could be recommendations, there could be guidelines, or there could be actual laws, statutes. But it's whatever is put into place that is the government wants to see, is the official government doctrine that needs to be followed. And that's another thing. Guidelines, that's a kind of a loose term. When you think about what a guideline is supposed to be,
right.
And by the way, they've been around in healthcare as long as I've been around in healthcare, and probably way before that. Guidelines are basically sort of general kind of pointers. So you can come to generalizations about the treatment of a particular medical problem, and experts who spend a lot of time studying it could say, in general, this is sort of an algorithm you might want to follow. But it's understood both by them and by everyone who's reading it that this isn't to be taken as the gospel. This is not cast in stone. This is just kind of a general helpful hint kind of thing. And it's understood that you may have a different opinion, or your patient may not fit the profile. It's there to help you. But when the CDC issued guidelines in 2016, and I know there are a lot of really scholarly people who disagreed with their guidelines to begin with and believed that a lot of them were based on very flimsy evidence. But aside from that, it was never intended to be anything other than that kind of helpful hint thing. It even said so. In their guidelines, they said this is not meant to be prescriptive, but rather a voluntary, suggestive way to approach things.
And then
it said practitioners know their patients better than anybody, and they should make the decisions based upon what they know about their patient and the risks involved. But people in the political world and in the policy world, they don't hear that. They just hear this is what you do. Yeah. So, for example, in those guidelines, when it said in many cases an acute pain can be managed with a roughly 3 days supply. 5 days supply of prescription opioids, and certainly more than 7 is more than adequate for most people. I'm paraphrasing, I don't have the exact words. But when I read that, I heard, so for a lot of people, 5 to 7 days is enough. I don't disagree with that. But I also know people who need much more, and I know people who need less. But when Governor Baker of Massachusetts heard that, he said, "Oh, there we go, 7 days. Okay, new law, no more than 7 days." That's not what it said to do. It said that many people, 7 days is enough. That was not a controversial statement, but now it is.
Yeah, and those guidelines really seem to set doctors in a frenzy, and then before you know it, every state has a different set of guidelines. And Rhode Island adopted a 60 morphine equivalent, and then Nevada adopted, and then before you know it, we're at 60, we're at 90.
Wow.
Yeah, but wait a minute, what's going on?
It's 90 in Arizona. Happened? It's 90, and of course you know that even that is a very poor way of judging things, because morphine milligram equivalents, that again is not one size fits all. I mean, comparing the morphine milligram equivalents of hydrocodone to oxycodone, for example, they're not necessarily the same thing. And it doesn't necessarily. There are many people who died on less than 50 morphine milligram equivalents of opioids, and there are many people who take 200 to 400 morphine milligram equivalents a day, and they're able to go to work and have a meaningful life. So again, it's not one size fits all. It was meant to be sort of a gauge, a guideline. That's all.
Yeah. And when I testify, and I'm like it's frustrating because you go before people, they have no idea what they're talking about when they're like, well, oh my gosh, why would anybody need 20 or 15 Percocet a day? Oh my gosh, they must be addicts. And now you go to pain management centers, due to the new guidelines, all patients will be reduced to 60 morphine equivalent by January 2020, and then it varies from state to state, and opioid hysteria just is taken over the country.
It's also arrogant. It's arrogant to presume that you know how much pain another person is in, and how much and what they need to relieve their pain. That's arrogant. I mean, I just don't, who does that? Does anybody think they are to even presume to say that, no matter how much experience and knowledge they have?
Have you written policy about the benzodiazepine versus the pain medication choice? A lot of people I advocate for. I think that's probably the cruelest form that people have been subjected to. Pick one.
Well, I don't treat pain management, so I really don't feel like I have any expertise to discuss that. I do know that there is a large number of the overdoses. The great majority, probably around 90% or so, are what we call polypharmacy or polydrug. And benzodiazepines play a significant role in that. They potentiate opioids. And then if you mix that with alcohol, it gets even worse. But I really don't want to comment regarding using benzodiazepines with opioids to treat pain, because I'm not a specialist in pain treatment, pain management.
So tell me, how can people follow your work? Let's go back to what's going to happen in October. You're going to be in Washington, I think you said October 3rd.
Yeah, I'm going to be there the whole week, but yeah, October 3rd from noon to 1:30 Eastern Time at the Hayek Auditorium at the Cato Institute in Washington. The conference is going to be called Patients, Privacy, and PDMPs, Exploring the Impact of Prescription Drug Monitoring Programs. And our speakers are going to be David Fink, who is at the Columbia University School of Public Health. And about a year ago, his team published a very large systematic review on the effect of PDMPs, and he'll share his data with us. I don't want to, it's like a little spoiler alert, but the PDMPs certainly may have contributed to dropping the prescription rate, but they may have also contributed to raising the overdose rate and the crime rate. We're going to have Kate Nicholson. Many of your listeners are familiar with her. She's an attorney and a pain patient advocate, and she's going to discuss the impact that PDMPs have had on patients in pain that we kind of talked about today. Then we're going to have Nathan Wessler of the ACLU in New York, and he's going to address the privacy concerns of PDMPs. It basically,
I love Nathan.
Yeah, law enforcement is basically going through our medical records without a warrant, and this is a privacy concern, and it's also a fourth warrantless search concern. And then we're going to have also a professor, Patience Moyo of Brown University, that's near you, Brown University School of Public Health, and she's going to give us an overview as well, a history of PDMPs, and address the issues raised by the three previous speakers. And then we'll have questions and answers. And pardon me?
What do you hope to achieve after this?
Well, I hope to. Most of the public is unaware that even I think most of the general public doesn't even know we have PDMPs. So what I'm hoping to achieve is to make the public and the press much more aware of what PDPs are, how pervasive they are, PDMPs, and how they may be negatively impacted. Even if they were well intended, they're having a lot of negative consequences. And so we need to revisit the whole idea of PDMPs. Should we have them at all? And if we should we use them in a different way than they're being used, that are being abused, being misapplied? So I'm hoping to stimulate a very important discussion on this topic. And then there'll be other...
Can people comment on that on the webinar, or are they just viewing?
Those people who are there in person, we're going to be... I'm the moderator, so I will be taking questions and comments from the audience in the auditorium, and I may be also asking my own questions. You won't be able to do that, unfortunately, online, but at least you'll be able to watch it live while it's happening. And of course, you're welcome to email in to me any comments.
Absolutely.
There are going to be other conferences coming up. I have a conference planned for December 5th called "Is It the Drug? Rethinking Conventional Views of Substance Use, Abuse, and Addiction." And that's going to be instead of a panelist with a podium, it's going to be a sort of a roundtable discussion where we're going to talk about just what is addiction, how are we responding to addiction? Does the drug hijack your brain, or is it more of a learning disorder? As I'm sure many people are aware, that's an important viewpoint. And must we force people into treatment, and what treatments work better than others? That kind of thing. And we have an interesting group planned on that. Jacob Sullum, who's senior editor for Reason Magazine, is going to be one of the participants. So is former Surgeon General Joycelyn Elders, Mitch Earlywine, who's a professor at SUNY Albany, who's a cannabis expert, Dr. Kimberly Sue of the Harm Reduction Coalition in New York City, and Stanton Peel, a very well-known addiction specialist. And we're going to be having a sort of a kind of a free-form discussion that'll go on for about an hour and a half on December 5th. And then in January, I have planned a conference dealing with the benefits of needle exchange programs, which have been shown also to get the hepatitis and HIV rate down considerably, and still are prohibited in several states. So, we're going to continue to have conferences. I'm going to continue to publish, and I'm not the only one at the Cato Institute who works on this issue. I have a fair number of colleagues who were working on this issue long before I arrived at the Cato Institute, and they publish as well. So it's always a good idea for your listeners to check the site, cato.org, to see what's going on there.
Yeah, and print this out. And it's important that the listeners print these papers out that have been published, so you can take these to your lawmakers, even though they won't know what the hell they're looking at. But the Cato, it's a big name, and people know Cato. So if you're listening and you're meeting with your lawmaker, or you've got your media set up for your rally, print this stuff out. We've got researchers, we've got Dr. Singer, we've got, Josh Bloom. Everybody spends, a huge amount of time that goes into this research and policy. You sound like a very busy man. I'm glad you found an hour to be with us.
Well, I appreciate the opportunity to connect to your audience.
Yeah, we have, and I see you on Twitter. I see you, so you can follow Dr. for Liberty. I believe that's your Twitter name.
It's at DR4 Liberty, Dr. for Liberty. That's my Twitter handle. Yeah,
thanks so much. I look forward to the October 3rd discussion about the PDMP, especially leading up to the October 16 rally. Hey, everybody, thanks so much for taking an hour out of your night spending it with us. Don't forget, you got to get out there and you protest. Be the squeaky wheel. The squeaky wheel always gets the grease. When you leave a gym workout, you never say, oh, I wish I didn't work out today. And that's how you feel at the end of a protest. You don't give up. You keep fighting. And remember, I get my strength from your strength. Have a great night, everybody.
Thanks for joining us for the DPP Rally Talk Show. Subscribe to our channel at DPP Rally Talk Show with Claudia on YouTube. Copyright 2019. All rights reserved.
We are sorry, but the show has ended. Goodbye.